Thank you very much, and I'd like to thank the organizers for giving me the opportunity to present the French healthcare system and the French Organization for Patient Safety. The objectives of my presentation is to help you to understand the French national safety strategies and priorities, to identify the different levels that we use in France in order to improve patient safety, and I will focus on the role of the National Autorité for Health, HAS, and finally to share the common issues and solutions in different countries. When speaking of the French system for patient safety, I have to say that the current organization was not defined by political anticipation. Actually, most decisions were taken after successive health scandals. The first decision was taken in 1989. It was not because of a scandal. It was the issue of an agency for medical evaluation called ANDEM, which is a grandfather of HAS, and which work on guideline and evidence-based medicine and technologic and practice assessment. In 1991, we had the first emergence of a public scandal regarding blood transfusion, since the National Center of Blood Transfusion delivered HIV-infected blood products from 1994 to the end of 1995. Immediately after that, we had another scandal regarding a private hospital for sport. And in the period from 1988 to 1993, 88 patients were infected by a mycobacteria localized in the water circle. So after these scandals, there were a number of decisions. First, the issue of ANAS, which is the father of HAS, and a decision for mandatory accreditation of hospitals. After that, other decision, very important, Vigilance Act, which decided to organize the coordination of vigilances mostly in a state agency called, at that time, AFSAPS, and now called ANSM. So vigilance for drugs, for blood products, for medical devices, for in vitro diagnosis devices, for psychotropes, for grafts, for cosmetics, and also at the same time the issue of an institute for surveillance of nosocomial infection and epidemiology. Another law in 2002 was for patients' rights and protection, giving patients access to all information in the medical record, and created an organism for compensation in case of no fault. Another big scandal in 2003 because of hate wave, leading to almost 20,000 deaths because of poor organization of healthcare system in long-term organization. In 2004, it led to a new law, and that was the date of HAS creation, and also another one for grafts, the biomedical agency. 2006, decision for accreditation for doctors, another scandal in 2007, and the last ones in 2010, 2012, regarding a drug used in off-label use, and the scandal of breast implants called PIP. So because of this scandal, there were a number of changes, But even now, we always have the mediatic pressure each time there is a medical fault. Despite these scandals and despite the mediatic pressure, and it might be a sort of French paradox, there is a global public satisfaction for healthcare delivery, which may partly due to almost full coverage social security or insurance. We also have a good access to care delivery and a limited waiting list. And the consequence of this global satisfaction is that until now, the healthcare system has not been a political issue in the elections. Recently, we had a survey by the French Institute BVA. It's an annual survey. In 2012, again, public health remained number one within public services before, for instance, police. 86 satisfaction, and the results are stable since 2006. That might be partly due to some good or encouraging results, and many of you know this paper showing that in 2002-2003, the mortality amenable to health care was lower in France than in other countries. So, who is acting for patient safety? Actually, there are many actors which are organized at the national level, the regional level, and the local level. At the national level, there is a mix of mandatory and impulsion policy, and sometimes financial incentives. At the regional level, we now have regional agencies who are planning, financing, and inspecting the health care organizations. And at the local level, there is a number of organizations involving professionals and patients or stakeholders. This busy slide is just to show the national level with the Ministry of Health and the National Health Insurance. There are executive departments of the Ministry of Health, the one called DGS for Public Health, the one called DGOS for Healthcare Organization, and the one called DREES for Evaluation, Studies and Statistics. You here have a number of agencies which has been created after the scandals I mentioned, and you have especially this one which is in charge of drugs, medical devices, vigilance and authorization, which is called the ANSM, the French Agency for Medical Product Security. You also have this one I already mentioned for epidemiology and infections, the blood transfusion, the grafts, the food and education, and the National Cancer Institute. And here is HAS, the National Autorité for Health, which is, as I said previously, a non-profit independent scientific body which is in charge of promotion of quality and safety of healthcare, leading to health technology assessment, to improvement in professional practices, by guidelines and by accreditation. At the regional level, we have 26 regional executive agencies which are in charge of the alert system control, but obviously also of implementation and evaluation. And at the local system, at the local level, we have local organization in hospital mainly, and the last law for organization of healthcare in France indicated that the hospital CEO plays a great role in accordance with the medical commission elect and is a general risk management coordinator who helps him, and he also has a drug management coordinator. These two coordinators work in synergy with the CEO and the medical commission, and they draw their action upon several mandatory human resources or technical subgroups which are elected. So in each hospital we have a quality and patient safety officer, we have an hygiene team, we have a direction of nursing, and we have different committees for infection, drug and medical devices, pain management, for instance. So I just want to give you an example regarding prevention of infection, which is one particular concern, and of course the same concern in all countries. So at the national level, we have two departments of the Ministry of Health which are in charge of the prevention of infection. We have the DGOS for Organization of Healthcare, and the DGS which is in charge of protection from epidemics and alert system control. At the regional level, we have a number of coordinating centers which are called C-Klein in different regions, which are in charge of controlling the inborn infections. And at the local level, we have a special team for infection control. For instance, there is a local committee for infection control with a medical or pharmaceutical doctor and an infection control nurse. There should be one infection control team in each big hospitals. All hospitals are in charge of filling in public indicators which are listed here and which are published by the DGOS and now by HAS. So these are these public indicators for infection prevention. One is for infection control organization resources in action. One is for alcohol-based unwrapped consumption recorded by the hospitals. One is for organization resources in action for the antibiotics. One is for the survey of surgical site infection. One is the composite indicators for the other ones. And the last one is for methicillin-resistant Staphylococcus aureus. So we can look at the results by survey performed by the National Institute INVS. And this is the 2012 survey showing a large, very large study with more than 300,000 patients in a large majority of healthcare organizations in France. And you see that the proportion of infected patients in this survey was 5.1%, which actually was quite comparable to the previous survey in 2006. And there is a little difference between the medicine, surgery, and obstetrics hospital, where the infection rate was slightly higher at 5.6%, and it was a slight increase compared to 2006, 7%. On the other hand, in rehabilitation and mental care hospital, there was a decrease in the prevalence of hospital-borne infections. There are also information regarding the bacteria and the use of antibiotics. Coming to the HAS platform and the HAS role, we have a number of guidelines, publication, but I would like to focus on two programs. The first one is accreditation of healthcare organization, which is a program mandated by law, an obligation to publish by public status and for accountability. The second one is accreditation of physicians with a high-risk activity, and this is not a mandatory program. It's a voluntary program which is professionally owned, confidential, and which is accompanied by financial incentive from the National Health Insurance. So, regarding the accreditation of healthcare organization, it's based on a self-assessment which is performed by the hospitals themselves, and there is an on-site survey by 650 expert surveyors which perform an external peer review. The decision process is based on criteria, a number of criteria, including priority mandatory criteria. And this leads to a range of 5 accreditation levels, from accreditation to non-accreditation, and the results of the 2013 survey are the following. You have 30%, 36%, one-third accreditation with reservation, one-third with recommendation, 18% direct accreditation, but on the opposite, you have poor results in 12% of cases, which leads to conditional accreditation with follow-up and new on-site visits, and in a very small number of cases, the accreditation was refused. The process is repeated every 4 years, and on this slide you have the successive accreditation process. The first one in light blue, the second one from 2006 to 2010 in pink, and the last one, which is just finishing in 2014, it's called the V2010. You notice that we perform visits and accreditation in all hospitals, public and private, meaning 2,700 hospitals, and it's a 4-year process with 600 to 700 visits and accreditation per year. We performed a survey by a specialized institute in 2012, and we're happy to have very positive points, and the most important one is that we have obtained a cultural level for quality of care, and the professionals who participated in this survey acknowledge a leverage effect of the accreditation for quality of care in the hospitals. This led to an improvement of quality structures and processes. There was also a market interest for the evaluation of clinical practice, which was rather new in France, and the development of transversality between professionals. But there were some negative points. For instance, what is the objective of accreditation? Is it only an assistance trying to help the hospital to improve themselves, or does it contribute to regulation? many professionals said that they work hard, but there is no incentive decisions. Another issue that was pointed is that it was a hard mobilization during 1 year, just before the visit, and after that, demobilization. And finally, there were some practical questions regarding simplification and articulation of this process with other visits, for instance, by the regional agency. And one important question is how to demonstrate the value and the impact of the accreditation process. So we decided to change slightly the accreditation process for the next step, which is called the V 2014. And in this new version of the accreditation process, you will ask each HCO to identify his own risk, which may differ from a hospital to the other, and to customize the procedure according to the identified risk. We also want to make quality improvement a more continuous process, and for this reason we have introduced what we call a quality account tool. We also want to develop patient-centered approach, and we have introduced the so-called patient tracer method. And we also want to develop more indicator based on clinical practice more than of process. Finally, we think important to enhance the management of HCO, but maybe more importantly, the management of clinical teams. And finally, there is also a great demand for a knowledge achievement, and we are currently evaluating a financial incentive from the Ministry of Health. Another interesting development of this hospital accreditation is the public disclosure on hospitals' quality, which is a new mission which has been given to HAS by the French law in 2012. The mission is to coordinate the development of an appropriate information on quality of care in all French hospitals. The objectives are first to contribute to a transparent and democratic health system by empowering the user to be an actor of his or her care. So the public information. But there is another objective, which is to use this public disclosure as a lever to improve the quality of hospitals based on the competition between hospitals. The first action was the launch of the website that we call Scope Santé in November 28, 2013. And this slide summarizes this website, which involves all hospitals, 2,700 hospitals and 5,000 hospital structures. We study and publish 110 accreditation criteria and safety indicators, including the infection indicators and quality of care indicators, and also 37 185 activity parameters. And the main objective, the main features of this website is first to summarize the results obtained in each hospital using letters from A, direct accreditation, to E, no accreditation, and colors ranging from green to dark orange. The second objective is to geolocalize the hospital on a map. The third objective is to use a multi-criteria search on a selection of items or criteria, which are the criteria which interest each user for his own information. And this search is also a tool for comparing hospitals, and we have a national benchmarking, but also a local benchmarking between nearby hospitals. The second platform, HAS platform, is the accreditation of physicians with high-risk activities. And in 19 specialties, physicians must implement practice improvement and fulfill accreditation requirements. The first one is to report a number of what we call near misses before an adverse event, an event which could have generate an even adverse event. So there are general and targeted near misses in each specialty. Second, to implement guidelines defined by the accreditation organization, which is specific for each specialty. And each specialty writes guidelines which is sometimes based on the knowledge of the near misses. Okay. The third is to take part in activity, and the fourth is to send an annual report. So this is a number of near misses which have been sent to organizations and to the HAS databases, which is used for writing guidelines and security or safety solution. And this is a number of accreditation which is rising. So I'd like to finish by showing the result of the study for this, evaluating the results of this safety organization. And actually we had two studies in 2005 and 2010 on a large number of wards in 71 hospitals, which showed the incidence of adverse events 6.6% per 1,000 days of hospitalization, which is comparable to figures in other Western countries, and which is comparable in two surveys, one in 2005 and one in 2010. So these are the adverse events during hospitalization and the adverse event caused, hospitalization admission caused by adverse event. 4%, 45% preventable. So this is a little bit of disappointment because there was no improvement between the 2005 and the 2010 survey. So it leads to a national safety programs for 2013-2017 from the Ministry of Health with 4 topics: patient participation, adverse event reporting and analysis of this adverse event, patient safety education, and research agenda on patient safety. And finally, we think that it's important for France to participate in networks, and HAS is coordinating a patient safety and quality European network involving 20 countries. We also participate in international programs like the Duke and the High Five programs. So to conclude, since 20 years, France has invested in safety governance at 3 levels: national, regional, and local levels. There are many actors which are coordinated and many actions. Currently, the results appear stable and comparable to those achieved in other countries, so we still have to improve, but we do think that the best way to improve is to take into consideration the current changes, technical innovation, sociological changes, public demand, supervision by authorities, and even very important financial crisis. So this leads to new challenge, new organization, and we think that we have to rapidly shift for always more in-hospital strategy to always more out-clinic and home care strategy, and to shift from safer medical acts to safer patient journey or patient pathway. I thank you for your attention.
Thank you very much indeed, Jean-Luc. Again, if we could have the lights up, just in case there are questions from the audience. Jean-Luc, I mean, France has always had this interesting paradox of very high satisfaction, and so in a way the people driving for change are not necessarily the patients or the public. But I just wondered if you could talk a bit more about how you therefore engage patients and the public in all of the initiatives. And the latest initiative had patients, several of the issues mentioned patient participation. What are you doing to increase that?
Well, first, yeah, you're right. The survey is not specifically for patients, although many French people may be or are patients. But what we are organizing, it's patient participation in the hospital, and there is a specific committee which involve users and patients. It's from the law, the 2002 law for patients' rights, but certainly what we call the rights of patients and sanitary democracy should be improved. And for instance, at HES, we involve patients or users in all our committees. But maybe it's not at the same level as in UK or in Nordic country where the patient opinion is systematically asked for.
Okay. I don't know that we get it very right in the UK, but Ed, tell us your thoughts on that.
Yeah, well,
Might need to wait for a microphone just on Ed.
If I could get them, thank you. Jean-Luc, thanks for the presentation, and just as someone who for WHO has been working quite a bit on adverse event reporting and infection prevention, and we were talking beforehand about this and about the leadership France has had in nosocomial infection reporting. I just wonder and also I have my own opinions on progress or lack thereof in safety at a national level, but I wonder if you might comment on Philippe Michel's the findings there and the no change between 2005 and 2010. Do you think that sort of not enough has been done in France on this, or not enough of the right things have been done, and what the reasons might be behind that?
Well, I'm not sure that we should be so pessimistic, because it's always difficult to make historical comparison, to compare 2005 and 2010, although the interval is short. But it might be major differences between the quality of patients who are in hospital and the severity of diseases, especially because of comorbidities and because of the life expectancy increase and more elderly patients. So you're right, it's partly due to misuse of the system or not adapted system, but it's also probably due to the fact that we don't compare the same patients. So, nevertheless, as I said, it's a little bit of disappointment, and it's pushed Ministry of Health and institutions like HAS to continue the efforts and to try and change the system. So that is the basis of the national program for patient safety, which is alluded to. And this is also the reason why we developed at HAS a number of new challenges. I didn't have time to mention, but for instance, for surgery, we did develop a checklist surgery. So we have many examples to try and improve this system, this in-hospital system.
Thank you. Just briefly, if you will also, Jean-Luc, about the healthcare professional involvement. So how did they, for example, how are they responding to the public disclosure of quality in their hospitals? And are you able to get that down to individual clinicians, or is that still at the hospital level?
That's a good question. I think that there are two situations. You have the hospitals and you have the private practice. In the hospitals, I have to say that when we did initiate the hospital accreditation, the physicians were not very much involved and not very much interested, and roughly as I said, let me treat my patient. I have no time to discuss this process and these complex questions. But things are changing, and they are more and more involved, and as I said, we think that management of clinical teams is very important, and involving physicians is very important. We do think that many of the adverse events are related to a problem of coordination within a team or between teams. So we are working on team accreditation, and I think that physicians are more and more involved. The situation is different for medical practice, because in France, until now, physicians work on a solo practice. Sometimes they share home, but they still work on the solo practice. Things are changing, and there are more and more what can be called medical homes with pluriprofessional cooperation in the same site or in different sites. With a solo practice, it's difficult to motivate the physician to quality of care, but there is one new disposition, organization written in the law, which is what we call continuous professional development, where all health professionals have to send a report regarding continuous training and improvement of their professional practices. It has been started in 2013. It's funded, so we hope that it will help to improve the level of quality of care also in liberal medical practice. But maybe the most important hope is for the medical homes, where people work together, and there might be a possibility to have a sort of medical team accreditation also in the medical practice.
Thank you very much indeed, Jean-Luc Harousseau.